As mentioned, I'm Steve Croft. I'm the immediate past president of the ASCP. When I was originally invited by Dr. Grisson to come give this presentation, I was still president of the ASCP, so I've been stalling for a while, and I finally did make it out. And I very much appreciate the invitation. And it's been a very exciting and edifying day for me and Jeff, I think, in terms of the conversations we've had with various of your faculty and residents. So we are going to talk today a little bit about healthcare policy and the future of laboratory practices. The learning objectives you see here are more or less what we're going to talk about today. We're going to try kind of an unusual format here. Probably don't have too many grand rounds with two speakers. We put the presentation together, and we worked on it in tandem. And while Jeff owns most of the first half and I own most of the second half, we're going to try to do a little bit of back and forth and tag teaming that may or may not work. Excuse us if we fumble or look awkward, but we are going to try this out. Jeff's going to start actually by talking about several major pieces of legislation that have come amazingly out of Washington in the last number of years that affect healthcare, some of which I'm sure you're familiar with. He's going to highlight some of the provisions that really affect pathology and laboratory medicine. These are highly complex pieces of legislation with a bewildering array of rules and regulations that I think almost no one truly fully understands. Part of the difficulty with these laws is that sometimes they even seem schizophrenic, like they're almost mutually contradicting each other, or even provisions within a law seem to be addressing different things or pulling in different directions. And I think the reason for that is because of the fact that right now we're right in the middle, or at least at some point in the transition from one fundamental mode of healthcare financing in this country, which of course is pay for performance, and we're moving away from that towards alternative models of financing and delivering healthcare. And it's the fact that we're in the middle of this transition that causes the confusion, because at the same time that the federal government is attempting to build these new paradigms for healthcare delivery and financing, they're also optimizing the fee-for-service model that they're moving away from, which can be very, very confusing. And so from that perspective, I think it's worth keeping that in mind as Jeff presents, because it is difficult to really comprehend how all these things are truly going to ultimately funnel down and impact us in this field. So without further ado, I probably already spent too much time. I will turn the microphone over to Jeff, and he'll start us off.
Great. Well, thank you very much, and I want to thank you for this amazing invitation to be with you today. It's really an honor to be with such a distinguished group of medical professionals, and want to thank you again on behalf of ASCP and all of us. So I want to tell you just very briefly about ASCP, and I think most of you probably already know a little bit about ASCP, but what I want to do is tell you what some of the pillars of what we work on are and what drives us. And we're a patient-centric organization, but knowledge, advancement, collaboration, and global community are our pillars. And then our mission is to provide excellence in education, certification, and advocacy on behalf of patients, pathologists, and laboratory professionals across the globe. We have 100,000 members. It's a multidisciplinary organization, pathologists and every type of laboratory professional. In fact, we just certified our 500,000th laboratory professional. We're very, very proud of that. So I have the honor of being in charge of our Institute for Science, Technology, and Policy in our Washington, D.C. office. I think you may know that ASCP's headquarters are in Chicago, and I'm in charge of the Washington office, and it's a real honor. And we have a Center for Public Policy, and we have Centers for Science, Technology, and Quality Practice. We've been building this over the last several years, and you can see here many of the things that we're engaged in. I think we're somewhat unique. It's a combination between a lobby shop. We are a 501c3, so we're a nonprofit. So we do lobby Congress, we do lobby CMS and the FDA and the other institutions in government, but we also really engage in think tank activities, and we also are engaged in many, many activities like health services research and the like. So we're building a very unique model there, and we're very, very proud of it, and I'm honored to be a part of it. You can see here just part of our advocacy agenda that was the 2014 through 2016. And many of these issues we're going to talk about today. I'm putting this slide up. I'm really not going to read the slide. But the legislation that Dr. Croft talked about, that I'm talking about today, and that we're talking about today, obviously is high on our agenda because the regulations that are coming forward from those pieces of legislation are affecting your everyday life in practice. And we're also going to talk about LDTs and other aspects of things, including the workforce. And this is both the pathologist workforce and the laboratory professional workforce. And you know, these are very, very important issues. And we are also a major part of the AMA. So we're part of the Pathology Section Council there, and we're honored to work with the AMA and the House of Medicine. So here are the major pieces of legislation that we're going to just really touch on today, because as Dr. Croft said, these are amazingly complex. The Tax Relief and Healthcare Act of 2006, this is really when quality became one of the central focuses of our federal government. The Patient Protection and Affordable Care Act, which all of you are aware of, PAMA of 2014, and what we call MACRA of 2015. And I think it's important to point out that a lot of this moved from volume to value and pay for performance and the like. Really, this is a bipartisan effort. This has been something that both parties believe in, and that there's a lot of synergy between the two parties in believing in moving us from volume to value. This is not owned by one party or the other party. Many of this began during President Bush's term. So I think, you know, it's just important that this all just didn't come out of the Affordable Care Act for you to understand. And I wanted to put up this timeline because I think this is really, you know, fascinating as we move towards the end of this decade. You know, again, going back to 2006, I talked about that. That's when the PQRS system was put in place. 2010, the Affordable Care Act passed. The Medicare Innovation Center at CMS, which is driving a lot of the volume to value initiatives that are there. Medicare shared savings, accountable care organizations, value-based purchasing at hospitals, and bundled payments, and also the Value Modifier program all came out of that. And you can see these have dates that run to 2016. And then in 2014, PAMA was passed, and they did not fix the SGR, but they did put in the clinical laboratory fee schedule revaluation. With that, they put a temporary payment patch on the SGR. And then in 2015, when MACRA passed, they put the SGR repeal in place, which was a godsend. I've worked in Washington many years, and I've worked on this issue since 1996 when it was put in place by the Balanced Budget Act, and it's a godsend that the SGR was repealed. And again, the alternative payment models, and then we'll talk a little bit about merit-based incentive programs, because PQRS and the Value Modifier program are going to phase out, and it's all going to be a merit-based incentive program starting in 2019. So, again, I won't spend much time on these slides. There's many other evolutionary implications for pathology, and some of these we're going to have to fight for, the consultative role, for example. But these are many of the transitions that are occurring in pathology, and I think there's a lot of opportunity, even though there's problems with all this legislation, and we're in the middle of chaos right now. There are opportunities that are coming out of this, so I wanted you to see a few of these elements here. We'll move on here to some of the terms of reform. Again, there's many, many terms of reform, but I think this is what's driving us, and these terms are becoming part of our everyday language. I want to go step back a little bit, because many people think that this major healthcare reform is in place and we're moving, but actually there's so many influences that are going to drive continual reform over the next couple of decades. In fact, I think we're at the beginning of healthcare reform. I don't want to scare anyone in the room. We're at the beginning of healthcare reform. We're not in the middle of healthcare reform. We're really at the beginning of it because of many of these aspects that are on this slide, and we'll just move right into them. The demographic pressures are going to demand additional reforms. The aging of the U.S. population has a direct effect on the demand for healthcare, as older persons generally utilize healthcare services more. And if you look at individuals 75 to 84, they use 3 times more health care than everyone else combined. And then if you look at the aging of the population, 2010 to 2050, the U.S. population over 65 years of age is projected to more than double, from 40 million to 88 million. And the 85 and older population is expected to more than triple, 5.7 million in 2010 to 19 million in 2050. And so, you know, you look at this, and I think you really are talking about serious reforms that are going to continue, and that we really are at the beginning of healthcare reform. We're not in the middle of it. We'll move on to national healthcare expenditures. I think everyone here in the room knows that we spend a higher percentage of GDP than anywhere else in the entire world on healthcare, and this is only going to continue. You know, these are snapshots of the previous year, but you look that we spent 17.5% of our GDP in 2014, and we're expected to spend 19.6% in 2024. And to be really honest, we've seen projections that rise almost as high as 30% of GDP as you move forward. And again, if you look back at that last slide with the demographics, you can see why with the aging population and the amount of healthcare services that they use. I think the other piece that you should consider here is the evolution of medical practice. This is something that, you know, this is changing. It's changing dramatically. If you look at the number of physicians who are employed by large healthcare systems, it's dramatically increasing. You go back to only 2000, looking at 43% in these type of systems, and then you go to 2013, and you're already at 67%. And everyone believes that because of the health expenditures and all of the pressures that are coming from this, we're going to be looking at higher and higher and higher percentages, and this probably won't end. And then that puts everybody in systems where many people are employed on a salary basis. And as we move away from fee-for-service, then that changes the dynamic on how the federal government can actually reimburse health care. So that's another factor to consider. And then, you know, this is the public debt. This is different than the deficit. When you hear people talk about the deficit, you're hearing people talk about a one-year snapshot. And that deficit has been decreasing with the economic upturn that occurred after the last downturn in 2008. So our deficit has been decreasing, but at the same time, our public debt is increasing. So again, you know, consider all these different factors, all the money that we'll owe, the money that our federal government has to be responsible for. So this is another factor that you should consider. Overall, again, we're mostly going to talk about Medicare Part B, but I think most of you are aware of the Part A, the Part B, the Part C, and the Part D. And Medicare Part B are the physician services, outpatient hospital care, and other medical services not covered by Part A. But again, you know, the federal government would even like to bundle many of the services in Part A, just as they've been bundled in Part B, just as they've been bundled in Part A. So there's a lot of interesting aspects there. This is the Part B fee schedules, and the three that affect pathology and lab medicine the most, obviously, are the PFS, the OPPS, and the CLFS, and you can see total Medicare spending $574 billion. I think the interesting piece of this slide, though, is if you look over at the clinical laboratory fee schedule spending in 2013, and of that 574, we looked at 9.7. Again, we're going to talk for a couple of minutes today about the clinical laboratory fee schedule revaluation and the impact that will have on the field, and that's something that's coming. This is the PQRS Foundation, which was, again, established in 2006. At that point, this particular program was optional, and it then became mandatory. And you can see here that there were incentive payments, although small and difficult and very difficult for pathologists to qualify for. There are some AP PQRS measures that the college diligently worked on. But then those payments, you know, started to decrease, and we're in the second year of decreases, and it's a mandatory program. So if you're not participating, then that has some challenges. And again, these are very complex, and I'm glossing over them because we've got a lot of territory to cover today. This is the Value-Based Modifier program. And again, it's a modifier that helps facilitate upward and downward payment adjustments to physicians based on both the cost and quality of the care they provide. And this is, again, a program that has a very complex formula, and that's why physicians have a very hard time practicing in small practices today, because it requires large billing departments to really figure out how to navigate these systems. And again, the value-based modifier program is going to go away just like PQRS went away, and we're going to have the merit-based incentive program. So we'll move on to PAMA, which was passed ironically on April the 1st, 2014. And that's where we had the 17th payment patch to avert the 24% negative cut that would have come to physician reimbursement. This also is where the CMS determined they would revalue the CLFS based on technological change. They changed that with a market-based approach, and we'll talk about that in a few minutes, because that was a very interesting change that there's many problems that we're looking at there. And again, this established appropriate use criteria, and it also revised a Medicare sequester. So even in the balanced this 2-year budget agreement that the government just passed, they even upped the Medicare sequester again, because at the same time where there's a physician update of 0.5% beginning in January 1, 2016, this particular Medicare sequester still has an overall goal of reducing Medicare expenditures. So you can see that the pressure is intense. Next, again, I think this was passed, if I'm not mistaken, on April 1st, 2015. I don't know why they like to do that. They like April Fool's Day. And this is the MACRA piece that thankfully repealed and replaced SGR with stable updates for the next 5 years. It sunsetted the current quality programs, penalties, and consolidated the programs into the merit-based incentive payment system. And it also provided incentives for the development of alternative payment models. And I think that when you're going to hear a lot more of in the coming years about alternative payment models. This is something that I think the Medicare Innovation Center at CMS and many of the health providers and health insurers and many institutions around the country are going to be experimenting with these alternative payment models. The macro bill also, this is the MIPS, so talk a little bit about this, that will be implemented in 2019. Again, it consolidates all the quality reporting into one compulsory quality improvement program. It evaluates physicians on a composite score, quality, resource use, clinical practice improvement, and meaningful use of EHR. Now, pathologists have a very hard time qualifying for many of these aspects, and it's not a bad thing that this is a composite score. It's probably good for the field, the fact that it's a composite score. And it adjusts these 4 performance categories and weighs them to reflect applicability to the specialty. And it also requires performance and participation in MIPS and alternative payment models be available through the Physician Compare website, which will mean all of this data will be public, and the public can access it, as well as researchers and watchdogs and all kinds of other groups. So something to be aware of. Now, this next slide I'm going to turn over to Dr. Croft to talk about.
The reason he's turning this over to me is I decided to put this slide in at about 2 a.m. and imposed on Jeff to insert it into the presentation. I just want to reiterate that MIPS is compulsory. PQRS was optional. You got penalized if you didn't participate, but you had the option of not doing it and taking the hit. And some healthcare systems and some groups decide to do that because the administrative costs of actually participating sometimes were not mitigated sufficiently by the benefits or the absence of a penalty as of recently. CMS recently released a statutorily required document, which was a draft proposal for development of measures. That was December 16th, which is about a 63-page, highly detailed plan for what kind of measures they're going to develop for this merit-based incentive program. It's actually, and I'm not even being facetious here, it's very interesting reading. But I want to highlight some of the key principles that are mentioned in that document because I think they're illustrative of what CMS is thinking, how they're interpreting this legislation, and how they're planning on implementing it. So they're tasked with developing an entire portfolio of measures, essentially, across the domains that Jeff just showed in the last slide. The only new one, by the way, at least in terms of a categories, is practice improvement measures. Various ways of demonstrating that you are taking action to improve your practice. So these are some principles articulated in the document. These are direct quotes from the document with a few words excised when they weren't necessary for this presentation, but they specify they want to address performance gaps where there's variation in performance, not just a measure gap, okay? So the idea is to hit the low-hanging fruit where there's actually opportunity for improving practice significantly. They want to follow patients across the entire continuum of care with one or more chronic conditions, and they're very specifically emphasizing outcomes, including both global outcomes, population-based outcome measures, and then also throw in some process measures earlier in the process to assure that people are doing the things they need to do to ensure these outcomes. They are going to address the patient experience, care coordination, and appropriate use, and I want to emphasize that. Appropriate use is really becoming a hot topic, and we're going to talk a little bit more about that later in this presentation, but they are specifically targeting appropriate use of procedures, diagnostics, et cetera, which of course is very important to us in the laboratory industry. And they also very specifically mention they're not just talking about overuse. They just don't want to police people and drive down utilization. They want to make use appropriate. So if something's being underutilized, they're going to try to drive change to appropriately utilize things that need to be done, which is important. So it counteracts the tendency to drive underutilization, which potentially could impact patient quality and safety. Promote multiple levels of accountability, including clinicians, group practices at the system and population level. And I guess the millions of letters we sent to them saying that PQRS wasn't applicable to pathologists finally got through to them because they specifically called out non-patient facing providers as being part of this, and that the system will be designed to accommodate us. And then they also specifically mentioned they want to use data generated from EHRs as much as possible based on existing provider workflows, because a big problem with existing measures is that they are not easy to extract from particular practices or information systems. So they want to focus on things that aren't disruptive of normal workflow, but can easily flow out of the normal workflow. So they're sensitive to the burden that they put on providers with these measurement systems. In fact, they're very sensitive, and one of their core principles is achieving a portfolio of measures that is not burdensome to providers. They want to incorporate broader use of clinical data registries, which is a very interesting topic of itself, but we aren't going to be able to touch on that today. And then finally, because of the excruciatingly slow way that the existing PQRS measures have worked their way through the system, takes forever, they specifically have determined to apply lean principles and rapid cycle measure development. And all of this, I think, is interesting, and it demonstrates an evolution in the way CMS is thinking about how they regulate us. So I'm now going to go back to Jeff.
Well, thank you. And again, as we move from volume to value, and you can see that CMS is already establishing targets. These are a little shocking, actually, but they published this target, and they're working hard towards actually achieving this. And you can see they announced this target of 30% of payments tied to quality or value through alternative payment models by the end of 2016 and 50% by the end of 2018. So you can see their expectations are very high. And again, the pressures that are coming to change the system are intense. This is a big piece, and this is something that is going to be very, very important, because since the CLFS established its payments rates in 1984, there was never a revaluation. There was never any kind of update to this, and there was very, very little change to the rates over the years. So that's what PAMA did. They determined that they would do a revaluation. It would be based on market pricing. They've established their estimated cost savings. This is what the federal government wants to save through this revaluation, $5 billion over 10 years and $360 million in 2017. And so you look at this, and their methodology that they are proposing is that this new payment would be based on the weighted median of private payer payments reported. The payment rate decreases and increases are capped at 10% per year between 2017 and 2019. And during phase 2, payment adjustments are capped at 15% per year from 2020 to 2022. And I think this is one of the problems with this, is that they have determined that the applicable laboratories are those having the majority of their Medicare revenue paid under the CLFS or PFS, and that the reportable payment rates are private health insurers, group health plans, Medicare Advantage, and Medicare Managed Care. Now our concerns with this are that hospital laboratories will likely not meet the definition of an applicable laboratory. Most independent laboratories and almost all physician offices are expected to be precluded from reporting. We've obviously objected to this. And rates will be set based on prices charged by systems with large efficiencies of scale and massive outreach. And that's going to be the reference labs. And we all know that while reference labs are doing some good work out there, they also have a lot of lost leaders, that they will underprice certain tests, and that will cause some real problems as the revaluation goes forward. That'll cause a lot of problems, actually. And another problem is their timeline in revaluing the CLFS. The final rule was due on June 30th, 2015, and it required that the data collection period be July 1 through December 31st of 2015. So, you know, think about all those multiple payers. Think about the different prices that folks have to, that the different entities are putting forward for different payors. And so, you know, consolidating all of that data is an enormous burden on laboratories. This is going to be an enormous regulatory burden for folks to do. And you can look at the reporting periods and the date of development, and the publication of new rates would be as early as November 2016. And the fact they didn't even release this rule on time, they didn't change any of the data reporting requirements. So it's created a lot of confusion and a lot of angst, and rightfully so, because this is going to be a major problem. So the CLFS revaluation, you're going to hear a lot about that in the coming year. And without further ado, we'll turn it over to Dr. Croft again.
So we're going to switch gears a little bit and talk about another thing that I think many of us are engaged in on a daily basis, and we're going to have to kind of ramp up and accelerate the way we engage in test utilization, basically appropriate use, breaking down and delivering the right test for the right patient at the right time. So I think one of our challenges, again, in this transition from volume to value is demonstrating our value. If we're going to be in an era of bundled payments and we're going to be competing for our piece of the pie, we have to be able to clearly demonstrate our value to both the healthcare system's fiscal health, but also to the quality and patient safety elements of patient care. And so one enormous opportunity for us, which many medical centers, many departments of pathology, laboratory medicine, et cetera, are seizing, is utilization. How we lead change in the way diagnostic services are utilized. So we're going to have to really focus on doing the right thing. We're no longer going to be incentivized to drive the volume. And we are going to have to deliver the best possible diagnostic processes. And I would reemphasize that we have to lead here. We can't rely on our clinical colleagues to drive this change. It has to be us as the lab experts to help them do the right thing. We have to build the systems to help our clinicians order the right test at the right time for the right patient. But utilization also incorporates not just how you order tests, but how you use that information. So we're going to be responsible for turning data into information and into knowledge, and helping clinicians apply that knowledge in the management of their patients. And this is all part of the task in front of us in terms of building support systems for decision management for our clinicians. So just a little background, I think you probably are all aware that there's a wide variation in the amount of testing performed for similar clinical indications, both between institutions and within individual institutions. And if you ever do that, if you ever go through the exercise of tracking how similar clinicians or clinicians operating in a similar environment with similar patient populations utilize testing, it's dramatic sometimes how variable they are utilizing testing for the exact same clinical indications, for example, a knee replacement. Interestingly, there's no data that the total volume of lab testing is associated with clinical outcome. That's surprising, perhaps, to some people. We all know that supposedly 70% of the medical decision-making is based on laboratory testing. So how can this be the case? How can the volume of laboratory testing not impact outcomes? And I think the reason for that is because we're so far out on the diminishing returns curve that we're on the plateau. We're not at the inflection point. And so there's no question that modern medicine would grind to a halt without the laboratory. But where is that optimal point of utilization where you've maxed out your value that you're adding to patient care? There's also no question that inefficiency threatens our ability to deliver the highest care possible to our patients. So what is the cost of unnecessary lab testing? One of the weird ironies of our industry is that while supposedly we drive 70% of medical decision making, we are only 2 to 3% of the healthcare budget. So to quote Aladdin, we have phenomenal cosmic powers, but an itty-bitty living space. So if you're going to just consider what the potential savings are based on a 20 to 30% overutilization, which I forgot to mention in the last slide, that conservative estimates are we overutilize lab tests 20 to 30%. I believe it's considerably more, actually. So if you do the math, $3 trillion healthcare budget times roughly 3% paid for lab times 30% of those, that's $27 billion annually. And it's worth emphasizing that labs are really moving towards being, at least hospital labs are moving towards being entirely cost centers, right? We are not revenue centers anymore, we are cost centers. Even perhaps more important than the upfront costs are the downstream costs of unnecessary testing. There's no question the more tests, all of you know this, the more tests you order, the more abnormal results you get. And abnormal results beget additional testing, additional procedures, even surgeries, increased length of stay, et cetera. And this was called the Ulysses syndrome back in about 1970, and it refers to Ulysses' indirect Odyssey home and that indirect pathway that we're taking to actually giving the best care to our patients. So choosing wisely, you must all be familiar with. It was spearheaded by the American Board of Internal Medicine Foundation, and it's one way to start chipping away at overutilization in this country. Basically, it was about engaging both patients and providers to reduce the overuse of tests, provide a basis for conversation about what isn't of value, what is potentially even of harm in terms of choices about tests and procedures. So it's intended to reduce costs that provide no benefit and to help mitigate tough decisions in the future about how care is delivered in the future. So one interesting feature of choosing wisely is that one of the major driving participants was consumer reports. So the consumer was a major target of this effort, to give consumers the information they need to walk into their doctor's office and say, I don't need that test, it's unnecessary. So we engaged in Choosing Wisely as the only laboratory organization in the country to participate in this process. And it has involved the entire spectrum of our membership, pathologists, lab professionals, and of course, all of our laboratories. And we really, again, emphasize the necessity of us taking a leadership role in addressing this. So we announced our first 5 tests in 2013 and the second 5 in February of 2015. And it looks like I've truncated this slide a little bit, but the third set of 5 tests should be announced within the next month or so, which I can't tell you what they are because they're top secret and embargoed. And that's the ABIM's rule, not ours. So shifting gears a little bit now to tie it back to what Jeff was talking about, PAMA and appropriate use criteria. So the Protecting Access to Medicare Act in 2014 directed HHS to establish an appropriate use program for radiology. And I'm going to talk about it in a little bit of detail because it's interesting. And we'll transition that to what this means for us in pathology. So as of January of 2017, providers who order certain advanced radiology studies will be required to consult an appropriate use criteria as a condition for Medicare reimbursement under fee-for-service. Eventually, providers with a history of low adherence to those appropriate use criteria will be subject to prior authorization before they can even order a test. So a few additional features before I again outline what this actually looks like. The appropriate use criteria per this legislation must be developed or endorsed by a national medical society or other provider-led entity. Provider-led entity, so that's us, okay? That has been qualified by CMS to perform this function. And go through some sort of application process and qualify to be a developer or endorser of appropriate use criteria. CMS specifically stated they will not be the developers of appropriate use criteria. They essentially tacitly acknowledge they don't have the expertise to do this. And the appropriate use criteria will be deployed through electronic clinical decision support mechanisms, which also will require qualification by CMS. So this is schematically what it looks like. You want to order an advanced diagnostic test. The provider has to go into this electronic clinical decision support mechanism, enter certain data elements regarding the aspects of the patient's demographics, clinical history, other conditions, et cetera, and the CDSM will spit out a rating. Appropriate, equivocal, or inappropriate, or something along those lines, okay? Then the furnishing provider, the radiologist in this case, would review the imaging order and the patient data. If they want, they can call the ordering physician. If they don't want to, they don't have to. And then perform the service and submit the claim to CMS. CMS will look at it. They'll verify that an appropriate use criterion was consulted, and money will, see those little dollar bills, will flow back to the provider of the service. What's fascinating is it doesn't matter, at least at the beginning of the program, what answer the system spits out. It just requires consulting the appropriate use criteria to order the test. But as I mentioned, eventually, if you keep ignoring the answer that's spitting out, then you'll be subject to pre-authorization before you can get the testing. So why are we even talking about this? And the reason we're talking about this is because PAMA included a provision for the Government Accountability Office, the Congress's watchdog. If you're not familiar, it's the independent, nonpartisan body that makes sure that Congress is spending our money appropriately, which is kind of hilarious, actually. But they include a provision for the GAO to report on the extent to which this paradigm could be applied to other Medicare services, including radiation therapy and clinical diagnostic services. And this is why we're talking about it. So in fact, the GAO released a report in September. It was called Considerations for Expansion of the Appropriate Use Criteria Program, that analyzed the advanced imaging AUC program, but also focused on, quote, 36 non-imaging services deemed to be of questionable or low value. 23 of those 36 actually already had appropriate use criteria developed by a provider-led entity. And for lab, the report specifically focused on ASCP's Choosing Wisely recommendation. So these are the ones they actually called out in the report. It's just 5 of the 10 that we've released. I'm not going to go through them. You've probably seen them. But the reason we're talking about this is because this is a little bit of a paradigm shift in how we're thinking about using Choosing Wisely and similar paradigms for designating appropriate use. Because up until now, and I'm sure you're doing it here locally, is folks have used these evidence-based guidelines to drive change in their own environments. They bring these to their medical staff, or they develop decision support tools in their LIS or their EHRs to help adhere to these Choosing Wisely guidelines, which I should again reiterate are highly vetted evidence-based guidelines. Now it's not just going to be a local effort. We have the opportunity as laboratorians to help CMS shape a program to ensure appropriate lab test utilization for the entire Medicare program. Okay? And again, provider-led entities. It's going to be your specialty societies. It's going to be CAP or ASCP or whoever who's going to be developing and submitting these guidelines, presumably, to CMS for appropriate use criteria. Now, I should mention that this AUC process for radiology was piloted through a collaboration with the RAND Institute in California, and it kind of failed miserably for issues that relate to the technical interfaces and the ability to actually get meaningful results out of these clinical data support mechanisms. But the theory is still out there, and the details have to be worked out. And again, that's still law. So radiologists are going to have to do this starting January 1st, 2017. So, and finally, actually, one thing I'd like to mention, I think I mentioned it earlier regarding appropriate use criteria. This appeared again in PAMA, but it appeared again in MACRA just this past spring. And MACRA specifically emphasized employing appropriate use criteria as one of their quality measures for practice, and in fact, again, called out choosing wisely as one potential program that is providing some of these guidelines for how to use these specialty tests or procedures. So I'm going to switch gears a little bit. Do you have any comments about any of that, Jeff? So with a little bit of trepidation, I'm going to talk a little bit about laboratory-developed tests. And the reason I have trepidation is because I forgot to wear my bulletproof vest. And if I say the wrong thing, I think there's a couple people in this room who might take me down. So
maybe not with bullets.
well, just warn me to duck if necessary. So this is a big deal. As you're all aware, FDA has proposed oversight of laboratory-developed tests. If you hadn't heard anything about this, particularly I think in this particular Department of Laboratory Medicine, you've got your head in the sand probably. So in 2014, the FDA released kind of long-awaited, this has been percolating for years now, guidance to step up federal oversight of LDTs. By the way, FDA defines LDTs as an in vitro diagnostic that is intended for clinical use and designed, manufactured, and used within a single laboratory. The oversight proposal that the FDA has put forward is similar to that they use for medical devices. And it's a 3-tier risk-based framework for enforcement of pre-market review requirements and quality system regulation. So the idea is you have to submit these to them for pre-market approval before you can start using them on patients. So a little more detail here. The FDA was proposing to phase in the review of high and moderate risk tests over approximately 9 years. Low-risk tests marketed prior to final guidance would be grandfathered and would not require any additional approval. They could just continue to be used. But after the release of the final guidance, which I should mention has not been released, prior approval of all tests, regardless of risk profile, low, intermediate, or high, would be required after release of final guidance, okay? So you have to submit any LDT, no matter what risk tier, to the FDA before you start using it clinically. And they would require reapproval of anything you modify. So if you modify an FDA-approved or cleared test, it would require additional or reapproval through that pre-market process. So why is this happening? Turns out the FDA has had the authority, at least according to most people, to assert this control over LDTs for decades. It's been in their pocket for decades, and they've exercised what's known as enforcement discretion. That's the jargon for not choosing to enforce their ability to regulate. What's changed? Well, I think as you're all aware, LDTs are no longer just the province of specialized hospital labs developed for niche purposes in a narrow patient population. They're now being developed at a rapid rate by commercial reference laboratories that sell this testing services, not just the test methodology or the kit, to other laboratories as their primary for-profit business model. And they've gotten more complex, and they often depend on complicated, opaque, and proprietary data analysis algorithms. So it's very difficult for most of us to figure out whether they're doing what they're supposed to be doing because of the opacity of this development process. And so at the very least, there's a potential for abuse, which is what the FDA is reacting to, if not, in fact, actual abuse. And there have been a number of examples cited of at least alleged true abuse of LDTs in practice. So what's going on? This is still in flux. The FDA is currently reviewing comments, including ours. They held public hearings about a year ago. Stakeholders were almost unanimously critical of FDA approval, a proposal. And that has engendered multiple competing alternative proposals that have been presented, which incorporate varying degrees of detail. We have a document, a diagnostic test working group, which is really a large reference lab consortium. College of American Pathologists and the Association of Molecular Pathology all have proposed ways to address an alternative to the FDA's proposal. So what are the issues to consider with LDTs? Well, basically the fundamental conflict is the necessity of balancing patient care, quality and safety with the administrative burden. That's really what we're talking about. That's the tension. And there's a justified fear that regulation is going to stifle innovation and patient access. Okay, when you start saying patient access, that gets people's attention, I think, in CMS and in Washington. It's, of course, a threat to business models and fiscal viabilities of certain clinical laboratories. It's not clear where should LDT oversight live, CMS versus FDA. There's concern about actually whether the existing agencies, both CMS and FDA, have the ability to even handle the increased burden of regulating LDTs. And there's, again, the serious worry about administrative backlogs with serious delays in bringing important diagnostics to market. Another thing to consider is the necessity of establishing both analytic and clinical validity, which is explicit in the FDA's proposal. Currently, under existing CLIA oversight, we in the laboratory only have responsibility for demonstrating analytical validity, which is what we do every day with every test that we launch in a clinical laboratory. Although I editorially say I think this efficacy of oversight of even demonstrating analytical validity is inconsistent within our existing laboratory accreditation framework. The FDA proposal is based on existing medical device regulations, but LDTs, of course, differ in fundamental ways from other medical devices, and it's even been suggested that the FDA doesn't, in fact, even have a statutory authority to do this. And there have been some parties that have threatened to bring suit if this is implemented, which is interesting. So the various competing proposals on the table have certain things in common. They all recognize the need for improved oversight. At least tacitly, they've ceded that ground because the horse is out of the barn. You know, whether everyone believes that this is true is immaterial at this point. Everyone has conceded that improved oversight is inevitable. All incorporate a risk tier scheme. All require some sort of demonstration of both analytic and clinical validity. I would mention, as an aside, that none require the demonstration of clinical utility, which is a different standard than clinical validity. Clinical validity is, does a test give you accurate information about the status of a patient, either presence or absence of a disease or the severity of a disease state, for example. Clinical utility is, does a test add value to the care of a patient that is not outweighed by the cost or the risk? None of them require that, and I think that is a little bit discordant with the national quality strategy that is being implemented now by CMS via these various statutes that we've talked about this afternoon. What's more important than where they have things in common is probably where they differ. This is kind of where the rubber meets the road. The specifics of the risk tier system that are being proposed are different. What constitutes low, intermediate, and high risk? The mechanisms of assignment, who does it? Who is the party that says this is a low-risk test, this is an intermediate risk test, et cetera? Who should own that? Specifics of what level of burden of proof is required for demonstration of clinical validity, and where should oversight live? So ASCP has suggested mainly CMS with a limited FDA role. AMP, Association of Molecular Pathology, has said virtually entirely in CMS within existing CLIA structures. The Diagnostic Test Working Group wants everything in the FDA for approval of tests, but oversight of test performance as currently exists would still live with CMS, and oversight of the practice of medicine would reside in the states. And finally, College of American Pathologists suggests that CMS would own low and moderate risk tests via deemed status, third-party accrediting agency, presumably them. That's merely an editorial comment. I hope I just didn't offend anyone in the room. And FDA for high-risk tests. So where else do the competing proposals differ? It's not clear whether legislative intervention is required or if oversight can exist within what we currently have from the statutory framework. What testing should be grandfathered? What are the specifics of exemptions and exceptions? Rare diseases, public health emergencies, low volume testing, things like that. What are the requirements for pre-market approval? So the DTWG says all risk groups require pre-market approval. CAP and AMP suggest that only moderate and high risk tests need pre-market approval. What adverse events need reporting, how modified tests should be handled, and even what constitutes a modified test. How much do you have to do to an SOP to make it a modified test requiring reapproval? And then finally, the necessity for public reporting of LDTs through a registry or another mechanism. So these are the fine details where these procedures differ. The most contentious parts are where it will live, though. It's whether it's CMS, FDA, or a combination of both. That's probably where the biggest differences are amongst these proposals. So what's happening now? Well, FDA is working on finalizing guidance with a release possible in 2016. Until recently, this slide said with probable release in 2015. And then we realized it was 2016. And we have no idea the degree to which stakeholder input that they've received will be incorporated into their final proposal. There's the possibility of legislative action. Both the House Energy and Commerce and the Senate Help. It's Labor and Pensions is the L and P, and I forget what the E is for the moment, but they both are considering legislation modernizing LDT oversight. The proposal that has gained the most traction in the halls of Congress is the DTWG, the Diagnostic Test Working Group proposal. And in fact, the House Energy and Commerce Committee circulated draft language for this plan with mixed reception. And they recently released a revised plan, which is about a 200-page document, and we're trying to review it right now. Preliminary review suggests there's probably nothing earth-shaking in it except for potentially one piece, which is a provision whereby after a certain defined time period, possibly 180 days, if FDA hasn't gotten to your submission, it would automatically get approved. That's an interesting piece. Whether that survives and whether that has any traction, we'll see. But that mitigates this concern of something getting mired at the FDA indefinitely. If it automatically pops out after 180 days, maybe that's not so threatening, right? Alternative proposals continue to evolve. What troubles me personally is that the process has really exposed deep divisions in the laboratory industry. This has been a wedge issue. The AMA has actually convened stakeholders and tried to broker a consensus proposal because as an industry, we're in much better position if we present a common front to Congress and CMS than if we are essentially fighting each other regarding what the best way to move forward is. And both CAP and AMP are shopping their own plans on the Hill. So to summarize, we really don't know how this is going to turn out. My personal, perhaps rose-colored glasses opinion is, while I think this will change the way we deal with LDTs, I don't think the sky is going to fall, but it's easy for me to say, and we'll see whether my crystal ball is accurate. So we left this last piece for the end because it's the one that we felt we could most easily leave out of this presentation. I will just mention that the Institute of Medicine has recently released a report that we actually provide some sponsorship for called Improving Diagnosis in Healthcare. And this is part of the Quality Chasm series that began in 2000 with the famous To Err is Human report, which really was the beginning of our evolution in this country towards building quality systems into healthcare. And this report focused on a type of error that had received virtually no attention previously, which is diagnostic error. And I'm not going to go through this in detail because we're out of time, but I will mention that there's a couple of recommendations that are specifically important and relevant to pathology and laboratory medicine. They really call out the importance of diagnosticians, and that includes both us and radiologists, as being part of the interprofessional teams that are delivering care, and mention that we need to collaborate with other healthcare professionals, and they need to collaborate with us in terms of improving the diagnostic testing process. And this third bullet point, I think, is really important, and there's a recommendation to create CPT codes and provide coverage for additional evaluation and management activities that aren't currently coded or covered. And this includes time spent by pathologists, radiologists, and other clinicians in advising, ordering clinicians on the selection, use, and interpretation of diagnostic testing for specific patients. In other words, they want to find a way to pay us for this value-added activity that we're doing already, because number one, it's the right thing to do, and number two, we're trying to demonstrate to our healthcare systems that we do add value. And the idea is to incentivize us by paying for it. And we're not the only specialty, by the way, that is seeking expanded reimbursement for evaluation and management. Other non-procedural based specialties like internal medicine are really interested in shifting some of the reimbursement from procedures to the cognitive aspects of caring for patients. And then the last one's interesting, greater emphasis on post-mortem examination research. And the reason for this is to try to build an evidence base around this very difficult and complex issue of diagnostic error. If you have not seen the report or taken a look at it, I encourage you to. While it is a couple hundred pages long, or 130 pages long, maybe something, the executive summary is manageable, and it's a very interesting read, and it does kind of call us out as the specialty that needs to step up and help advance the cause of ensuring diagnostic accuracy. So with that, I think we're going to stop. I believe it's exactly 4:30 at this point, and either Jeff and I will be happy to entertain any questions. And thank you so much for coming and for your attention.